Alert and Oriented RN, a podcast for nurses by nurses, where we talk about everything nursing and life. You're going to need some restraints and a bedpan because you don't want to miss this. Let's get Alert and Oriented. What's up, A&Os, and welcome to episode 7 of Alert and Oriented RN, the podcast for nurses by nurses. Of course, I'm one of your hosts, Luke, and as always, joined by my best friend and colleague, Tori. Tori, say hi to the people.
Hello, everybody. Welcome back to another episode. And let me just say, I'm very happy to be sitting here physically with Luke this time. We're back together again, guys. Can't separate us. Again, maybe. I don't know. Life sucks right now.
Yeah, well, last couple of weeks it was a little challenging, so being able to record that episode apart from each other was really nice. To still be able to put out the content, but it's always better to just be sitting right next to you.
Yeah, and it was very, very nice because I feel like last episode we both just needed to vent a little bit, and we do this podcast for you guys to give yourselves a platform, but also it's kind of nice to have a platform ourselves to be able to vent and talk about things that are going on. It's nice to relate to each other, but we missed you guys a lot. We're very, very, very happy to be back physically together and to be putting out more content for you guys. So how was your Thanksgiving? Everything good?
Yeah, it was good. It was nice. I had the front part of it off because I thought I was going to work Thanksgiving, and I ended up getting the day off. But I worked like Wednesday, Friday, so I sandwiched it. But had the first part of it off so I could go visit my grandparents who I hadn't seen in a little over a year. Aww. So that was nice. So I went up to go see them, and then Thanksgiving Day just had lunch with some of the in-law side of the family and everything. So it was nice. What about yourself?
It was good. I had 2 Thanksgivings. It was really nice.
Yeah.
So, and then we did a gender reveal for my brother and his
I saw
wife.
that.
Yeah,
I saw that.
They're gonna have a little baby girl.
I saw
I'm
that.
Super excited. It's their first one. So I'm gonna have a little niece.
Oh,
I can't
so
wait.
sweet.
So
you're gonna spoil the hell out of that thing.
Oh my god, yes! I'm already going dress shopping. I can't wait.
So what do you wait? You're gonna wait like 6 months or like a full year before you take her to Fredericksburg?
Probably 6 months.
Okay.
Let's be honest.
That's fine.
Yeah, because I think her mom is gonna need a little wine adventure.
Oh, absolutely.
For sure. My brother's wife is working very hard. She's working full time, planning events for work, and then also pregnant, and then also doing upkeep of the house. So
that's cool.
She's doing
that's awesome.
So I'm super excited for them.
Well, that's really cool. Yeah, that'd be awesome. So is it safe to say that maybe that's your feel good moment then?
That's my feel good moment for sure.
Yeah, that you're becoming a aunt. That's awesome.
I'm gonna be an aunt.
That's cool. My feel good moment. Let's see. It's December. So I know everybody's always like, oh my God, it's the end of another year. I'm pretty excited because when it turns 2022, I will be in the calendar year of my graduation.
Woo!
Yes. So that's exciting. And I love Christmas. And I feel it. I feel like this is it's going to be like a normal Christmas. You know what I mean? Like I feel like the holiday cheer is there again. People are like, I'm going to do stuff. Like I'm not going to have another holiday taken away. And I love that. And I mean, because that's how I'm going to be, and then, and of course, the best part of every single one of my years for the last 6 years has been the last day of every year is my anniversary. So great way to end it. So year 6 is coming up. So
that's so exciting.
I'm in
year 6.
Yeah. Year 6.
Stop.
I know. Yeah. It's crazy.
My God, that's crazy.
So I like December. December's November being my birthday. It's a good time of year. So good feel good moment right now. But still got to finish through 2 more weeks of school. So got to push.
Oh my God, that last little push. How much time do you get off in between your semesters?
I actually get a month for Christmas. Which is awesome. Nice. Yeah, I get a month, and then when I go back in January, it's just a continuous push through August. So it'll be nice because, like I said, I'm going to fully just do absolutely nothing.
Good for you.
For December. Got a couple trips planned, and then that way, hopefully, I can go into the last. Well, I mean, I guess it's 26 weeks because it's like end of January through like the end of August with no real break in between. Just straight push of clinical last 2 classes and graduate. Let's do this thing.
Yeah.
And then decompress and take boards. But that's way down the line. I'm not going to talk about that right now.
Yeah.
So
I digress. Let's
but no, good fun time of the year. Always fun, especially in our line of work at times because
it is fun being in peds and it's Christmas time. Mm-hmm. That's what I like about peds a lot is like we get Halloween. Mm-hmm. We get to like decorate the unit. We get to dress up. Kids look forward to it. They get to go trick-or-treating. And then also we have Christmas. So I think I mentioned one time on a podcast, I didn't know how Christmas worked, like, being in peds. But yeah, we get to customized little Santa sack.
Yep.
Donate
Yes.
money, donate toys, because they go to use.
Yes.
Like
Absolutely.
And think of all ages too, especially I would say like the teenagers,
Mm-hmm.
because we get a lot of like Barbies and like stuff that's like anywhere from like 12 and under.
Yeah, I feel like a lot of times people forget. Not, I don't want to say forget. That's bad, but it's when you think of pediatric nursery or children's hospital, you think of the little ones. You know, like, and they I think sometimes it gets lost there for a little bit that you do have some older kids that are more. They're closer to those adult interest kind of things and stuff. So like gift cards are huge.
Gift cards are huge
Because I mean, teenagers eat and they love to shop. So general gift cards, Amazon, stuff like that is great. And those come in huge handy too, because we can also use those as presents for as a family gift to help alleviate, like grocery cost or anything that they might potentially need when it comes into the holidays, especially if they have to spend it in the hospital,
I know. It's awful. Because when you think about like, I have to work on Christmas, like think about the family that's there. And that
See, I get excited. I love working Christmas right now because I don't have any little ones at home. And so those are my little ones. I dress like Santa. It's gonna be year 5 of dressing like Santa at work. Year 5.
It's pretty solid.
It just stinks because I still this year, since we're going to be in masks, I still won't be able to paint my beard. So that's why it's not as thick or like as long as it usually is this time of year, because I have to wear a mask anyway. So, but I have a bearded mask that I got last year, but still not the same.
So if you guys are working Christmas, dress up. Try to make it special for you. Like it's fun for you because come on, we're peds nurses. Like we want to have fun. Yeah. Like, yes, obviously our job is very serious. We take everything very seriously, but like, let's have fun while we do it. Please.
Absolutely.
Yeah.
Yeah. It's important. It's for the kids, for the family. Nobody wants to be in a hospital on Christmas, whether it's an employee, family member, or the patient itself.
Whether it's an employee, family member, or the patient.
Yeah. No, I mean, let's get real. I mean, I would rather wake up and go sit on my couch or, be with my family on Christmas, but at the same time, try to make the best of the situation. So, but that's interesting that we started talking about that, because this episode, we've been having a lot of people reach out and ask and stuff. And we were kind of waiting for the right time to bring up this topic and kind of have an episode that revolved around it, because we wanted it to really encapsulate everything that we wanted the people to get out of it, or that they wanted out of it. And that's specifically pediatric nursing. So at this point, 7 episodes in, better part of a year doing this podcast. If you're, a daily listener or, a biweekly listener, that me and Tori both specialize in pediatrics, ICU, oncology, and transplant. So it is our world. It's been our world for, 5 years or so. I mean, for me, it's been my world since I just had to get through, school essentially to be there. Tori a little bit later, but she found her passion and she's killing it. So we wanted to bring some content to kind of like, how did we get here? Tips and tricks of making it through pediatric nursing, how to approach it, and then also kind of talk about some of the heavier topics that do come up in this line of work, because unfortunately, not everything is sunshine and rainbows in pediatric nursing, which I wish it was, and the majority of it is, but unfortunately there are sad times, and the way that you handle and get through those times are a trick of its own and very important and stuff too. So, I guess, just to start it off, if I had to ask you, what is the one thing that you would tell somebody that, that you think is the most important when it comes to pediatric nursing? Like when you think back on like what your job is the last 4 or 5 years, and you're like, man, and somebody asked you like, hey, like pediatric nursing, you got one sentence, like what would you say?
I would say always, and I feel like this isn't necessarily PD specific, but this is very nursing specific in general. Always, always, always go with your gut.
That's a good one.
Always, always, always. Like that goes for when you're taking a test. It's always the first, like never change your answer unless you're 100% sure that your first answer was incorrect. I would say always go with your gut and your gut feeling. But to be more PD specific, I would say listen to the parents. I really would. And I know that like a lot of people are like, oh my God, like this mom in bed 12 is like so annoying. Don't even go in the room. We're on our phones texting each other like, hey, like, can you call me on the walkie and get me out of here? No, like I digress. Yeah. Like besides that, like we have family members that talk all the time. That goes for adults and pediatrics. But I would say also listen to the parents, because maybe what you're getting in report This happened to me the other day. I was just telling Luke, I got report on a patient, and went into the room, and like the vital signs and everything were just not on par with what I got in report. And so I was like, okay, he had like stepped out of the room to go do something. So I like asked the mom, I was like, hey, like, is he uncomfortable? What's going on right now? That heart rate is super high. I didn't get that in report. Like, he seems a little irritable. This, that, and the other. And just, I would say, always trust your gut and ask the parents. It's their kid. They know them. They're the reason. They knew that something was wrong with them, and they brought them into the hospital.
Yeah, absolutely.
So they know what their baseline is.
Well, but then that's so true, because the biggest thing, if you're in peds, you probably just listen to that and you're like, well, yeah, that is spot on. If you're thinking about getting into peds, or you have some experience within it, whether it's just a little bit in school so far, or you're pretty fresh into the actual specialty itself, it's huge, because the biggest thing in pediatrics so what I would say is kind of an extension of that, and closely probably the same thing, is you got to remember most kids. So the majority of kids that come into the hospital, right? Like, they were fine up until that point. Mm-hmm. You also have to remember that even an 18-year-old is young, and really, what life expectancy is like 85, 86, something like that year. So 18, when you think about only 18 years, like that's not even a quarter of the way through their life. Yeah. And it's really hard in 18 years to make a whole lot of decisions that pile upon itself to add into like comorbidities, right? We've talked about that before, but so you have to remember that, like, okay, up until that point, they were probably normal, which isn't a good medical word to use, and so when something seems wrong, it probably is. Mm-hmm. The other thing is kids will compensate the shit out of everything until it's literally too late. Yeah. Or not too late, because there's always things, but they will, like an adult, they'll start decompensating, or, something like that, where you're like, oh, something's happening. A kid, you'll be like, man, they're doing really, really well. Hour later, WTF. Yeah. What is this? Yeah. What are you doing? Stop.
Yeah, I would say definitely look at those early signs, especially like from a respiratory standpoint, because kids will decompensate. Well, they'll compensate, they'll tank. So that's kind of what we mean by that. So like, especially with respiratory season, like in full effect and full swing, it's going to get even worse. You have these kids that are like, hey, you know what? Their heart rate's up. They're a little irritable. Their respiratory rate is up. They're more labored. Their stats are dropping. Those are signs that you need to recognize those, and you need to say, okay, do I need to reposition this kiddo? Does he have a temperature? Like just do your assessment on them. And, also I would say trust your assessment skills. Get your baseline assessment in. That way, something's different. Like an hour later, like, hey, they weren't doing this at the beginning of my shift, or hey, they didn't do this for day shift and they're doing this for me. That's so important, because kids will tank super fast.
Yeah, it's different. And we kind of talked about this before we started recording, if you get into the specialty, you'll be exposed to it because you have to. But the biggest thing with kids is they're not adults, and they don't present that way. And so, like, all of nursing school trains you towards adults, because that's the majority of the population. That's where the majority of nurses, when you come out, whether it's bedside or some other type of specialty, you're going to be exposed to what is considered an adult patient or an adult client, not a pediatric one. Well, they present differently. Their baseline vital signs are different, and they change as they get older and get bigger. So, you have a 6-month-old, what is resting or considered a normal, appropriate heart rate is different than a 16-year-old. Now, on top of that, okay, you have the 6-month-old, and this is their normal, appropriate heart rate, but their baseline, because of something they've got going on or something like that, is actually, this is their appropriate heart rate. So now you potentially could have what is considered normal, abnormal for that patient. That's the world of peds. When you think something's normal, it's not. And then when you think that's normal, it's not too. Oh, it's just how it is. And it's
one of the first assignments I ever had was this kid who was a little cardiac patient, and his heart rate baseline was like in the 30s. Yeah. And I'm like, okay, well, PALS says that I need to be doing compressions below 60. So I'm like, what is it? I should pace you. It's important to ask what is normal for my patient.
Exactly.
As well.
Yeah. And then, like you said, parents are huge when it comes to that. You'll find families and parents, especially ones of like, chronically ill, but like you can have a chronic condition and live a very healthy life. So families that have been dealing with some type of underlying chronic condition, disorder, syndrome, anything like that for the child's entire life, if you can tell they're reliable, are huge.
Yeah.
Huge helps when it comes to that, because if they can sit there and you like, man, it sounds like this kid is not doing real well, and you walk in and the parents confidently are like, oh no, they're very much close to baseline.
He does this.
He does this. It's like,
Oh.
okay, well, and then explore that a little bit more. Ask some appropriate questions and stuff, because that's just good nursing. But then you're like, oh, okay. And then when you relay that to the provider or something like that, they're like, oh, that drastically changes my approach too, because I thought if parents are saying, no, this is baseline, cool. And that happens more often than you think.
It really does. Yeah, it really does. Especially if the child can't speak for themselves, if they're nonverbal, something like that. Like, your parent is going to be like your number one indicator and the most reliable person that you can talk to about their kids.
Especially in the majority of settings of pediatrics.
Oh,
Our two settings, obviously, we see kids for a lot longer than what would be considered a normal hospitalization for most kids. So it's like we get to know that baseline of that kid, at least, especially for me, because like I usually do get to see the kid at some point of what is considered the most healthy they're going to be while in said treatment, right? Because I mean, when you're still in treatment, you're not necessarily going to be fully healthy. But when they leave, I know, like, okay, because we don't discharge anybody unless we can confidently say, okay, this is good. It might get a little bit better, but like you're not going to get worse unless something's going on, kind of thing. Because like we're not going to just be like, oh, hey, there's your last chemo. See you later. I mean, some protocols are like that, but there's a little bit more intricacy to it. But same thing for you. I mean, obviously for you, like a lot of times you don't discharge from an ICU, you step down. But at the same time, like you get to know a kid, and you're so closely watching them for so long that you kind of you start to, oh, okay, I know what this is. Okay, I had him for X amount of days, or me and such had him for X amount of days. This is what was going on, and now I've got, even a subtle change could be huge, and you catch that because you're like, I know this is not right.
Oh yeah, no, I had a 1-to-1 for 5 nights last week. I was on for 5 in a row, and God bless my charge nurse for putting me on this 1-to-1 assignment, because I had the same assignment for 5 nights. And so, yeah, like you said, by the time I was done with that kiddo, I wasn't even looking at like my brains for my report.
Yeah.
Like, I knew baseline, exactly where they needed to be, what they should be, and what was normal for them. And so, yeah, like your assessment skills are just going to be the most important whenever you're doing the pediatric population. And yes, and what we were taught in school as is normal, or what PALS tells you is normal, is not always normal.
Right.
So I would say that pediatrics are very, very specific. And I think it's a shame that also that you don't get that much pediatric like time and that big rotation. But when I was interviewing people, when I did peer interviews, I was like, oh, so where did you do your clinical rotations at? People were like, oh, we went to a daycare. What? Or like, oh, we went to like this organization that takes care of like chronically ill kids, and like we went and helped. And I was like, what? Like no, like you need to be in a hospital setting. And I mean, like, I feel like you can really, really benefit from that. And that's going to make your decision whether or not you want to do pediatrics. You could have gone to like a daycare. You're seeing all these little healthy kids running around, and you're like, oh, I want to do pediatrics.
Yeah, but at the same time though, it's still extremely beneficial, because if you come from, like, I was lucky, like where I fell within the generation of my rather large family. I had a lot of little cousins by the time I was already like an adolescent, teen, high school, and stuff like that. So like I was exposed to how to interact with kids of all ages, infant, toddler, school age, stuff like that, to where like if you don't know how to interact with a kid or change the way that you approach certain things based off of developmental level, that makes your job extremely difficult too. So, I mean, there are some benefits there, but yeah, no, you're 100% right, because there's not really, outside of like school nursing, I don't really know of any type of pediatric nursing, or can't think of one off the top of my head right now, where you're not dealing with ill kids. And so if you've never been exposed to a facility or something like that where you're dealing with ill kids, getting thrown into it right out of school and stuff like that can be a little like, oh, maybe this wasn't the right decision for me.
No, I would say, because I mean, like you brought up, you said that you when you were an adolescent, you had all these young cousins and stuff. I didn't have that, like, at all. Like, my younger cousins the cousins who were younger than me who would have helped with that, literally lived in different states. So I was the youngest as far as all that went. I think I mentioned in one of our first podcasts that I almost made it through my entire pediatric rotation without
not changing a diaper. Yeah, I remember you saying that. Yeah.
And so literally I was like, oh crap, like wings down, like this was new to me. And it's hilarious when I think about it. But I would give advice, like I wish that I would have, like I nannied and stuff like that, but those kids were older. They were like, I think the youngest kid that I nannied was like 5. And so you have these infants that are a huge part of your population in pediatrics.
Yeah.
You know, anywhere.
Side note, if you do put a diaper on backwards, it won't work.
It won't work.
You'll come into a huge mess.
You know what? Forget my advice earlier.
Yeah.
Wings down.
Yeah.
That's if your patient is prone or if they're normal. Supine. Wings down, always with a diaper.
Yep.
But I would say also just general advice, like go be a nurse's aide on like a pediatric floor, just to see if you're going to like the environment. Because sometimes an environment, you know, or to see if you even want to work in that facility.
A lot of places will just even let you just shadow.
Yeah.
You don't even have to like commit to taking an actual job. You can, if you reach out or something like that, you can actually shadow. Because the other thing is, if you're already in nursing school and you're considering it or you're going up, you can utilize your professors or clinical instructors more than just like what you get, like because they do have connections or they used to work at certain places, or at the worst they know people that graduated before you that work in those areas and they can put you in touch and stuff like that. Because I mean, you can, I had somebody shadow me like a couple of years ago that like was in nursing school, thought they wanted peds and didn't really get like a full rotation or something like that. And so instead of taking a full job and committing, because it's hard to commit to a job, especially in nursing school, they just shadowed me for a couple of days. And I was put in touch by one of our former professors in nursing school that saw, and I cleared it with my director and stuff. And she's like, yeah, that's perfectly fine. Like if they want to come for X amount of hours and just kind of see the flow. And so a little bit different, I guess now. I mean, this was before COVID and all that stuff. So, you know, all of that bull crap and how that still gets it. Yeah, whatever. So,
and then also some directors are like, no.
Yeah, some of them, exactly. But it's I mean, you have to. The biggest thing you have to seek out what you hope to get in return. Yeah. Because again,
I think that Luke mentioned this earlier too. Is like nothing is going to be handed to you in this job. Like if you want something, you want a specific area, you're going to have to go get it. Yeah. So.
Well, and pediatrics isn't something you just jump into like, oh, I think it's cool. Like it is cool, and I mean that's why all of us get into it. But like, if you don't really know what you're expecting, or that like this is something you wanted to do, or that you fit, because again, if your personality doesn't fit, like, you're spending the majority of your week because you know you're now a professional working, so you're spending a good chunk, if not the majority of your week, hanging out with an age group between birth and young 20s, depending on what special. So
some kids.
If your personality doesn't, if you're like, man, actually, you know what? Like, now that I think about it, like, I really hate when like kids are running around the living room at my family's gatherings. Probably shouldn't work in pediatric nursing. Yeah, probably shouldn't. You know, me, I was the opposite. I was like, I really just hate hearing adults talk. It's annoying. I'd rather play games and crack jokes and laugh at things that are probably inappropriate. I'm gonna work with kids for the rest of my life.
I have to share probably like just like the most hilarious thing that's ever happened to me, I think, as a pediatric nurse. Well, by the way, you're gonna get insulted.
Yeah, kids.
They're so brutal.
God awful truth. They will absolutely tell you the absolute truth.
I had a kid one time that was, what was it? And so think about like the different age groups and stuff and how these kids find and search for humor. They're in the freaking hospital. They're bored out of their mind. But so I had a patient one time that we were weighing him and we get on the standing scale. I like roll it out and I was like, okay, like go ahead and get on the scale. Like, let's see how big you are today. And he gets on there and I'm like, yay, you gained weight. I'm so proud of you. Like, awesome. You know, we do like a little happy dance. And then he goes, Nurse Tori, get on the scale with me. And I was like, oh God. All right, so I get on the scale with this little kid, and he goes, I bet together we're going to weigh 1,000 pounds.
Yeah. It's so innocent, but at the same time, it's like a little like just like a knife to the side, like not an actual stab, but just like a little poke. Like, ooh.
I had a kid that I medicated one time. I was putting a Foley in her, so I gave her some morphine and some Versed to she was wild, and so she was all happy after that, right? Like put the Foley in. Parents are outside talking to the doctor, so I'm in there with her. And, I always have like little fun things on my badge. Like I have like a little Dumbo pin, all this
Yeah,
stuff.
the Kronk pin.
Just stuff for like kids to kind of like look at. And she looks at my badge and she goes, "Oh my God." This girl is like young, like probably 4 or 5 years old. And she looks at my badge photo and she goes, "Oh my God, is that what you used to look like?" And I was like,
you're like, is that a good?
I was like, when I was young and optimistic, yes, this is what I used to look like. Work in the ICU for a year, it'll change you.
It's okay. I just had my so I just recently turned 30, right? We talked about that in the last one. So I just had my 30th birthday, which is, deemed, I guess, a big birthday within the adult world or whatever. Anyway, so I had my first, I think, reality check of like, I guess 30 is considered old.
Oh no.
Because I had a patient the other week and we were talking and she was asking, she really wants to be a nurse. Thought she always wanted to be a nurse and then got diagnosed and everything. And now she's like, all it's done is just, I need to do this. I need to get through this part of my life, recover, become a survivor, finish school, go to nursing school, and I need to do this. And so it's like right on. So we're talking about my nursing experience and all the other school, what I had done leading up to it and stuff. And she was just like, wait, so like you went to college and then you went to college and now you're back in college, but it's 3 separate times. And I was like, yes, yeah, long path. Most people, you can do this or whatever. And she's like, wait, so like, are you kind of old? And I was like, I mean, I don't think so. Like, do you think I'm old? She's like, well, when did you graduate high school? And I told her when I graduated high school. Now she's 17. So let me preface that. So she's 17, senior in high school. I told her when I graduated high school and she sat there and thought about it for a second. And I was like, you okay? And she's like, I was in first grade. And I was like, all right. I do now feel old because a 17-year-old where I'm like, oh man, like we're buddies. Like we talk about the same movies. Yeah. We're hanging out. It's cool, whatever. Like just officially it was like, oh no, I was just fresh out of diapers when you graduated high school, essentially. Yeah, when I graduated high school.
Oh my God.
So I was like, okay, I think I'm going to go now and cry a little bit. Yeah, they'll tell you the God honest truth. It's amazing. And they'll throw you under the bus too. I had a kid, he's probably 7 or 8 year old, used to always play Nerf gun fights with. It was awesome. Or, saline flushes. That straight up mom was in the room. We were having a Nerf gun war and like something happened. He was like, oh shit. And mom's like, what did you just say? And he's like, Luke said it yesterday. I'm like, bro. And she of course, like, she just like looks at me and she's like, well, first off, Luke wasn't even here yesterday. So where'd you learn that? And then he's like, oh, brother, my brother says it when he's playing Call of Duty all the time. I'm like, dude, bro, stop throwing people under the bus, man.
I know. Yeah. Me and your brother. Who else?
Yeah. But it's hard because then like you're sitting here and it's like, it's kind of funny. And then you look at the parents and like, they kind of want to chuckle too. Cause like, it's this cute, innocent 7-year-old that like, he's only heard people say it. And like, it's not really that bad, but like just the way that it was said, and it was said at a what you would consider the right time to say it if you're going to say something like that, right?
It's completely appropriate.
And it's just, I don't know. It's great. It's just great being a pediatric nurse. But it's, it's freaking kids. I could tell stories like
so
this.
Many stories. And I think that's what I love so much about it is I have so many freaking stories that like I never would have. Like, I just go to work and I'm like, oh, I just thought I was going to be doing this. And, like we have our kids that are intubated, sedated, all that stuff. But like when you have the ones that are like, they're off their sedation or, you see how they react to sedation. It's just, they're hilarious.
Yeah. And it's rewarding in a sense too, because you might spend the majority of your effort or the most actual time just getting this kid to like, I don't know, accept you or respond to you. Like they're not non-compliant or anything like that, but you're like, I just want a high five.
Dude.
Like, I just want to get to a point where you'll high five me. Oh, and then when they finally do it, you're like, oh.
I had a 2.5-year-old this past week. See, that's beautiful for you. I will never, ever, ever ask a kid for a high five.
Why?
Like, okay, so this kid literally hates everybody, right? Like he's 2.5, super fearful of the stuff. And so like, I don't want to be like, hey bud, and like going for the high five. And then
I don't do it to introduce. It's when they're done.
Oh my God. Because I feel like the nurse who I got report from, he was like, yeah, he gave me a high five. And I was like, I would never, ask a kid for a high five because I don't want to look like a jackass when I'm standing there with my hand up and they don't respond.
Well, that's why you don't put your hand up when you say, you just say high five first.
Oh, that's
and then if they put their hand up or whatever, like, oh, nice.
See,
unless they're too young, then you got to kind of like, like basically like shadow them into like, hey, this is what you do. And they're like, oh, because
Or
they're
like
like,
fist
oh,
bump.
that's what we, but
Yeah. There's a little girl that was walking around with her little chest tube or whatever, and she's like ambulating. And I was like, "Hey, girl!" I was like, "You look so good. Look at you. You look so pretty. Like walking around." And she went in for the fist bump, and I was like, "I like
Yeah,
this.
fist bump's
I
cool.
like this where we are."
Yeah.
Yeah. So I would say fist bumps for
Yeah.
sure.
Absolutely.
But yeah, I would wait for the patient to initiate before. I would never ask a kid for a high five. I do like that advice though. High five, and then like let's
See
do a
what they,
high
yeah, see
five,
what they
and
do. But,
wait for
okay,
them.
that's cool. Yeah. Yeah. But maybe also too, like maybe I'm just cooler. So like maybe I just get more high five.
I
don't
had
know.
one of Luke's patients, actually, who he knows very well, and she earned herself a little ICU bed. But she was like completely appropriate and all that stuff. And I was asking Grandma, I was like, "Oh, do you guys, know Luke?" Blah blah blah. And she was like, "Oh my God, yeah." She goes, "We love Luke." She goes, "Well, I don't really know if she loves Luke."
Yeah, she bosses me around so much.
And I was
she refuses
Yeah.
to let me dance, sing, or watch anything that she's watching.
Smart girl.
Because like that's her thing.
That's
she's a
her thing.
singer and she's a dancer, and so like it's to the point where like I can hear the music and it's like, okay, I've got to go in the room anyway, so I try to like casually, quietly sneak in or whatever, just so. And as soon as I'm in the room, pause. Pause and stare. It's a pause and stare. Like,
what the hell do you want?
Like just tracking me. And then literally as soon as the door closed, I will hear the music or the video resume.
No.
It's like, and I'm yeah, I don't know. And it stinks because like I love karaoke. She loves karaoke. She just won't let me karaoke with her.
You know what? And you got to respect that.
But she'll let some other people karaoke. I don't know. I know I don't sing well, so maybe I just don't have the voice for her. So she just doesn't. Yeah. No. Yeah.
I would say keep trying.
Yeah, because it's hilarious. And next time, like if you see Grandma again, like you have to ask her because it's like she'll do everything I need her to do without fighting. Hey, let's take our meds, and she'll open her mouth, take her meds, and stuff like that. But nope. Yeah, will not play music, will not play videos, will not sing, will not dance, nothing. Like just straight up, it is dead quiet in there. Other than like being compliant to take her vital signs, her assessment, like she's got no problem doing that. She'll answer my questions, how she's feeling. But yep, nope, no singing and dancing. Breaks my heart, man. Breaks my heart. But it's okay. God. I'll get there.
We gotta all accept rejection.
I'll get
sometimes.
There. And the other thing is like she will not let me sing Little Mermaid at all because that's her favorite movie. So that's a hard no.
That's a hard no.
Like she'll literally, if I start singing it, she will just start like,
she'll sing
to cover it up. Yeah.
She's like, listen, just stop. You're ruining my favorite
great,
song.
Man. Kids are awesome.
They're the best.
Kids are awesome.
I would say, so sometimes with pediatrics, they always will have like a parent with them, but I get it. Sometimes they're single parents or, they're out of town. And there are some kids that will be left alone. And I really haven't had like a toddler that was like, could ambulate and do stuff that was left alone unless it was like an emergency. But I would say put on some music for your kid.
Yeah.
If they're chronically ill or something like that, they can't move, put on a movie for them. Put on some soft music. They have their shows that they like to watch, just so you know. Like an iPad will literally be
everybody has a comfort.
Yeah.
Everybody has something that's comfort.
I would say remember that too. Everyone's got a comfort. Music is a big one. That's why music therapy is actually like a job. Yeah. People will come to the hospital.
Oh yeah, they're awesome. Like we have a great art therapist. We have a great music therapist that comes around and stuff too. Absolutely. That is actually solid advice.
And I would say like I'm night shift though, so I don't really get to see all that stuff, which kind of sucks.
Yeah.
So there's so many movies that I'm like, oh, you want to watch Coco again? And they're like, yeah. Like they never get tired. And the parent is like.
Oh, have you ever gone to work on the day the movies change?
Oh, I don't think so.
You've never.
Oh no.
Yeah. When they update the movie, like there's some that will never leave, right? Like Frozen's been on the movie selection since it came out, and that's like 2008. So we're talking 13 years. Coco's been on there since it came out. That's never going to leave. Moana's been on there since it came out. I think that was 2012, something like that. The fact that I know like these dates of most of these movies is
it's supposed to show you.
I'm honestly impressed and very proud of myself. But anyway, oh no. So yeah, because it changed. I don't know what time it changes, but it changes sometime overnight when they update the library or something like that.
No.
So technically, it usually I think they have it timed probably for a time where most of the time kids aren't awake. right?
Mm-hmm.
But it doesn't do anything to the TV. So they could be watching a movie that like maybe it's not on, and then like when it's stuff, it's not there anymore, right?
Oh, that breaks
It
my heart.
is. You want to talk about probably the most devastating thing for a child,
No.
especially while they're in the hospital, and like that is like their comfort thing,
Mm-hmm.
is clicking the TV back on one day, especially ones that can like tell you like what they want to watch or anything like that, and being like, turn on blah blah blah, and you're like flipping, you're like,
Oh shit.
well, these are in alphabetical order, so it should.
Mm.
Is there anything else you want to watch today? Like this other one's not working for a reason. They're like,
Yeah.
it's not even on there. Oh, dude, talk. That might be
Oh,
like, and
I'm
there's no
caught.
heads up, from
There's
the
no
technology
heads up.
department. Like, hey, this is when the
It's like
movies are
Netflix.
updating and stuff.
You know,
Yeah.
like think of like your favorite show that gets taken off of Netflix or your favorite movie, and you're like, like you talk about heartbreak. Think of a
Well,
child.
I think it was even like a couple years ago at our facility where like they took off The Lion King. And it's like, okay, first off, The Lion King's been one of the top movies of all kids since like ever, since it came out. And then it wasn't until a couple of days ago I actually just realized it's still on. It's back on there, and it's the animated
Okay.
cover. So you're like, oh, Lion King. Because I like exposing the kids
Yeah.
to
Classic Disney.
our Disney, right?
Classic
So the
Disney.
Old School Little Mermaid line, and I'm like, oh, cool. It's still got the. You click on it, nope, it's live
It's
action.
a live action.
Which
Isn't
is
that
still a good movie, but it's like, okay,
Mhm.
this is fraud.
Yeah.
It's fraud.
Honestly, false advertising.
This is animated Simba that I'm looking at right here, and now you're taking me over to freaking Beyonce and Nala.
Mhm.
You know what I'm talking about? No, no, it's fraud is what it is. But no, it's crazy. Yeah, it's
There's times too when like, okay, so I had a patient that was also he was poor thing. He was just like pretty neurologically devastated, and normal kid before
Mhm.
he came in, and then had like an AVM that malfunctioned or ruptured essentially. I mean, you can go through your entire life with an arteriovenous malformation and not pass away from it, but
Mhm.
poor thing, his ruptured, and so you're in there, and when I will let you know when your kid is intubated and sedated, they can still hear you.
Oh yeah.
They know what's going on. So put some music on for them. But I asked mom, I'm like, what is he like? Does he like music? Does he like movies? What does he like? And she was like, he loves football. And it was Sunday. I'm like, let's put on football. And so I could just tell it really chilled him out.
Yeah.
Heart rate kind of started to come down a little bit. He seemed way more calm. Like you guys would be amazed of the things that your patients will respond to.
Oh, absolutely.
And so there's times too when I'm in there and I'm just like, man, this football game's real
Oh,
interesting.
I work a lot of weekends because of school and clinical and stuff like that. And during football season, there's nothing better than like when you do happen to get that one patient or the family that likes football and your assignment's like okay for the day. And you're like, you know what? I'm just going to chart in here. Like, let's watch sports. Or when you have the empty room and you have that little downtime to just kind of like just sneak in there and be like, all right, what game's on?
Parents are like, you want some wings? I'm like, yeah, I'll take some wings.
Yeah, that's a good one too. Oh yeah, it's awesome. But other thing I wanted to talk about, it's not within it, is because of both of our specialties. I have found, and I've always thought this way and stuff, the extreme importance of having at least a minimal understanding of what's going on with all, if not most of the patients on the floor is so important in pediatrics. And probably adult nursing too, but it gets a little harder because when your ratios change, drastically, it's really hard to be like, well, I'm going to go ahead and know a little bit about said person over there. But in R2, where a lot of it is such long-term care, it pays off to kind of have a basic understanding of what's going on with your partner's patients at the same time, because one, now you can become a better resource, and two, you might have that patient tomorrow. That's one of the things I love the most about my specialty, is because unfortunately we get to know the kids so long because their care is such a long time. It's not all consecutive, but I mean, for the better part of a year to a year and a half, we see them more than we don't see them. Right. Yeah. So you get to know them, but so I could not have somebody for, 3 or 4 days or even 2 weeks, but I still you kind of know what's going on because you listen and stuff, and you take that initiative to find out what's going on, so that when you jump back into that care, you're assigned that patient, like you're not starting over from scratch. That's so important. At least I feel like it's so important.
I agree. I would also say not ever throw away your report sheets.
Oh, I do that.
I was gonna say, put them in your locker or something. Because when you go over the history of the kid, you're like, oh my god, it's so long. There's a girl on our floor right now that's like a permanent resident,
Yeah.
and I never throw away that report sheet because her history is so extensive and so long, and everyone has taken care of her. And I won't have her for weeks, and then I'll come back and I'm like, here we go again.
I mean, I keep my report sheet like if I'm back the next day and I expect to have the same assignment because
sure.
like we do continuity of care, but like yeah, I mean that works for you, doesn't necessarily work for me. I mean, that's the other thing is you got to find what does and stuff like
I
that.
keep it as a reference. I don't keep it to write on it again, but I will keep it and be like,
yeah, if you need to like review back, that's actually not a bad idea.
Yeah, I'll just glance at it and I'm like, oh, this is
me. Yeah, see, so for me, when people are like, oh, hey, what's this kid's history? I'm like, yeah, they have cancer.
Well, I guess it is two different specialties, so yeah.
No, I know, but it's just
they have cancer.
Yeah.
Goddamn.
The looks that you get on your face is like, I know, like, but no. So,
oh my god.
That's the other thing with. That's what's so great is because like the only reason that I feel comfortable saying that or having that response or even saying it on the podcast is because I get that back from my kids.
Mm-hmm.
Like especially the AYAs, the adult young adults.
Mm-hmm.
I enjoy taking care of those patients. Like it's really fun. My preference is like the 3 to 7 year olds. I just think that's just such a fun age and it's just great. But I enjoy the whole, spectrum of ages and stuff. There are some institutions and stuff like that where like young adult oncology and pediatrics are actually separate and you can specialize in either or across. I would work both, but the adult young adults, that's what's so great because like, that's how you can tell that they're actually are having a good day or they're feeling better because like, and every nurse knows it. It doesn't matter your specialty, right? Knock, knock. Hey, I'm Luke. I'm going to be your nurse today. Or obviously for me, I don't necessarily have to introduce myself very often, because I know the kids, but it's like, hey, what's going on? I'm going to be your nurse today. Like, hey, how you doing?
Yeah.
Dead stare, completely serious. I have cancer.
Stop.
and then, you might know this kid for a year, but you're like still frozen in your tracks. Like, all right, which way is this going to go? And then it busts out into a laughter, and you're like, okay, first off, you can't do that. Secondly, that's extremely cruel. But then, like, obviously, they bust out in laughter. Now, I will say there are some instances where that does get said, and it goes the other way, and you're like, oh, okay, so we need to explore this because. But no, it's just. I mean, we could spend probably 4 or 5 hours talking about just our jobs and everything like that and stuff like that. But it's just great. But with that being said, though, we've shared a lot of happy moments, skills and techniques or tips and tricks that like have worked for us or that we've learned or that we've witnessed that were good and we took it into our practice and stuff. But at the same time too, this was a big topic and stuff that kind of came up a couple times from some people that were interested that does, affect our world of pediatrics and our two probably more so than others because of the specialties. But unfortunately, we don't always have success in everything that we do. And so we do lose patients. In your specialty, a lot of times you see some very acute cases that kind of just come in. You're their last kind of hope of a freak accident or a freak injury or something like that, and it doesn't go well. Mine, a lot of times, is usually a little bit more slower progression and stuff like that. But, and that's, coping and dealing with death and dying of a pediatric patient. So obviously the moods has now changed to a more somber thing because it's not easy to talk about, but it is important because there's a lot of things that go into it. From the way that you care for said patient, the way that you approach families, the way that you care for that family, but then also how you care for yourself. Because again, you get to know these kids and these families really, really well over a short amount of time, really realistically, when you think about it. I mean, like I know I always talk about like I get to know, I know these families for the better part of a year to a year and a half most of the time, but in reality, that's actually still a really short amount of time. They were introduced to me a year ago and now all of a sudden, we're super close, but like for the first 16 years of their kid's life, they had no idea that I even existed. You know what I mean? So in reality, it's just short, but and it's tough. So I've shared kind of, I think in the past, more so my thing, but the one thing I want like you to share about, because again, both subspecialties, but
Mhm.
I feel like mine's even more of like a littler niche, whereas yours, you see, and what I mean is you see a more widespread arena of diagnoses
Mhm.
and patient, I guess, situations. Because right, we've even talked about it multiple times. Like you get my patients
Mhm.
when they get to a certain point. So how? Let's see. Let's start with this. How do you approach said situation when you come on, or you've heard through the grapevine to prepare you, like, hey, this is anything, when you know you're walking into that situation where the outlook doesn't look great,
Mhm.
or it's already been told and that decision by that family member or whatever is about to be made? What's one thing that you do on your way to work or before you actually take over care to prepare yourself?
So I would say, and I've had some cases like, well, like Luke says that he will see his patients for a year and a half at times. There's been cases where we'll be like, oh shoot, so and so is here. Whether it's like a frequent flyer, someone from HEMOC, someone who's been downgraded, upgraded several times,
Mm-hmm.
and you're like, oh shoot, they're here, and it doesn't look good. And you kind of like will walk into work, and you already know, shoot, I already know who this person is. I know the parents, like all this. There's also situations where you don't know the family at all. This is your very first time meeting them. And I'll just share, I had a patient one time who went into cardiac arrest at church camp and came in. And so it was my first time meeting the family, my first time seeing this patient. You walk in and everyone's crying, and you're getting
Mm-hmm.
report, and you can see in the window, it's, what is going on, and it doesn't look good, and it doesn't look
Mm-hmm.
promising. And like you said, we're sort of their last hope. I would always, like, for myself, just mentally prepare myself and saying, like, okay, like, I need to be very cautious the way I approach this.
Mm-hmm.
I shouldn't be laughing with my coworkers. I need to be respectful of the family. I'm not going to be cracking jokes with my coworkers and laughing inside the room. You need to be respectful.
Mm-hmm.
Yeah, we're at work and we want to have a good time, but there's a time and a place.
Mm-hmm.
And I think it's really important for people to know that, because you're seeing this family on the absolute worst day of their entire lives. And so I will tell myself, okay, like, I need to be on my A game. I need to be serious, get rapport, establish rapport with the family immediately, because you're a brand new face to them and they're trusting you with the complete and total care of their baby.
Mm-hmm.
Whether it's a teenager, an actual, infant, um, just their child, their entire world. They don't even know who you are, and they're trusting you.
Mm-hmm.
So you need to come in with confidence and say, hey, address the patient first. Even if they're sedated, intubated, whatever,
Mm-hmm.
introduce yourself to the patient. Say, I'm going to take care of you today. Hey, mom, dad, I'm very sorry for the circumstances. Tell me a little bit about your baby.
Yeah.
And I always will start off with something like that.
Mm-hmm.
And then I say, okay, yeah, like, I'm so and so. I'm going to be taking care of you guys today. This is the plan for the evening. If anything, anything comes up, this is the physician who's on tonight.
Mm-hmm.
And I will fill out my whiteboard. I would say whiteboard is a very, very effective tool in the ICU. I didn't really think so on the tele floor, but I'll write down there, hey, this is the doctor for the evening.
Mm-hmm.
This is me. This is what day it is, and this is what we're going to do tonight.
Yeah.
So always tell your parents, hey, we're going to go for CT at 5 a.m. Like, they need to know that stuff. For us,
Mm-hmm.
it's routine, but for them, they're like, wait, where are you taking her? Wait, who's this person?
Yeah.
And I also do tell my parents, hey, anyone who comes into the room needs to be introducing themselves to you. They need to be introducing themselves to the patient, and they need to be telling you why they're in that room and why they're touching your child.
Yeah.
I think that's very important.
Yeah.
So I would say, like, mentally, I just am like, okay, like, I'm on my A game. I have to be on my A game, because these families deserve that.
Yeah.
With that being said, also, if the outcome goes south and you don't get the outcome that you want, I typically will sit in my car after my shift and kind of decompress, because when you're at work, it's like, okay, I have to call, the police department. I have to do this, and all the postmortem care and stuff. And you're at work and you're just so busy and you're thinking about, okay, I need to do all these things, but also you need to take care of yourself.
Uh-huh.
So I always like to decompress in my car and kind of like replay, okay, what just happened, with the music off, like, just focus on yourself and say, okay, what just happened? Maybe and just kind of debrief with yourself. You should always debrief after a code in general with the physician, but I think it's important to debrief with yourself and say, okay, what could I have done better? What can I do next time in that situation? Maybe identify something faster because we're their lifeline. Identify something a little bit quicker. Maybe I should have asked for help faster. Maybe I should have done XYZ before. But it's also important to not be too hard on yourself. So I think that a lot of ICU nurses that I've spoken with are, they're very, very hard on themselves. They always think, hey, what could I have done better in this situation? Is this my fault?
Well, and it's a mentality, right? Because when you work in an ICU, there's nothing above you. Like there is no next step, which I think at times can get certain types of ICU employees in trouble, right? Because then if all of a sudden he's thinking, I'm the cream of the crop, I'm the top of the thing, it can cause problems in the other direction. But at the same time, it can be so much more harder on y'all self than you necessarily need to, because, and this isn't the way to put it, but in y'all's eyes, I feel like a lot of times, and I'm not trying to put words in anybody's mouth or anything like that, but like, you can't fail. If I fail, there is no one else. Like there is no one else. Like they come to me because other stuff didn't work or they weren't responding, and now we're the team that needs to fix it. There is no next step. When you, and it sounds bad, when you can only leave the ICU in two ways: better than when you got there, or no longer in pain anymore at all, right? And so it's tough, and I don't envy y'all's position from that standpoint, because again, like I said, you can come into a situation that happened less than 24 hours ago and never met this family before. Nobody's ever met this family. They literally rolled in 8 hours ago from some freak accident that was just happened, and instantly have to kick into a situation where it's like, I am no longer in a role of potentially saving. I'm in a role of what I consider guiding. And it's tough. And I would say, to add on to that, like that's very well, I mean, it's huge. You're right. I mean, you have to bring your A game, but I would add on to that if you have to drastically alter the way that you're approaching a night because you know that that's the situation you're rolling into, then something that you then say the night before you didn't, there's a problem there, because you should be, there are things that you're going to have to change about your approach to things when you go into that situation that is not a daily part of your nursing care. And that's just tenfold. But if you're having to drastically alter your approach, your persona and stuff like that, because you're in this situation now, then how you would approach a kid that's actually doing really well, you need to look in the mirror there and stuff like that. But it's, yeah.
And I always think that you should be a little anxious before you go to work.
Yeah.
I don't think I've ever gone to work and like driven to work and like not been, I wouldn't say like anxious to the point to where you're just like stressing yourself out, but you should be on your toes.
Yeah.
Always.
Absolutely.
Because I'll be thinking about it. I'm driving to work. I'm like, okay, what am I going to get tonight? This, that, and the other. Still to this day, there's time. I mean, like I said on previous podcasts, like I really do study outside of work. And I think that you should always be studying and trying to like further your education, because this profession is always evolving and changing. But also, it's very broad. And so with kids, there's a lot of illnesses that maybe you've never heard of before, you never learned in school, that I'm like, okay, like I really do need to go up and read up on this. I haven't heard of this syndrome, but you're at work and you need to be on your A game and focused, and you don't have time to necessarily look up the entire background of this child, but you need to be focused with what's in front of you. Okay, they're here for hypotension.
Yeah, if you are too confident, you can get in trouble.
Oh, yeah, absolutely.
There is a thing as being too confident when it comes to healthcare, and it's not a good thing. Having confidence, though, that's built off of study and preparation and experience, that's different. Being overly confident because you just think that, like, you know what, like, man, I've been like on top of my stuff the last 4 days. Like, look at this. It's going to get you in trouble as soon as you're that. But so it's interesting. So I always feel weird talking about this and saying it, because I mean, it's always approached, with the right approach. But so because of where I work and what I do, and knowing that I always wanted to do that, I had already taken a special interest into the area of end of life care. Because unfortunately, like I said, we win a lot, and we win a lot more than we lose. But unfortunately, we do lose. It's just an aspect, especially of my specialty, and it's an aspect of like we do have those freak incidents where things just kind of happen and stuff goes. But for the most part, you see it coming. There's I don't want to say there's preparation, but you can certain things happen in a row, and you're like, you know what, like this didn't work. There's nothing after it, and things like that. You can see it, so it's a little bit more. I guess you could say you have more time, which has its pluses and minuses because then you dwell on it a little bit and stuff like that. But so I have a special interest when it comes to that, always have. And so I've taken the liberty to try to be better at that point because I believe that every child and every family has the right to have what we would call an end of life care, dignity in death. And so what that looks like is that there is a nice way to move into the next life. There is. Yeah. I'm not saying it's happy by any means. It's never happy, especially when you're talking about a child, right? Because they're young, they haven't even experienced anything. But there is a nice way to move into
something more ethical.
The eternal life.
Yeah.
Yes, and so there's appropriate ways to approach it. One of my biggest things that I've learned in all the years of studying it and making it a part of my practice that's preached within palliative hospice, end of life medicine, is trying to quickly identify that indirect family member that looks like they're taking the role of like the liaison. So typically, I mean, at least in my specialty, right, you have when somebody gets the big C word thrown at them at the bigger family that they haven't even probably seen in 15 years, all of a sudden comes out of the woodwork. Oh my God, I'm so sorry. And it's a blessing and it's a curse. That's a whole different story. But when you've gone a year to a year and a half, or, maybe shorter, whatever treatment, those other family members slowly start to kind of sprinkle back out, kind of thing. They wanted to be there for the initial thing because it was, all this stuff, or they're, but towards the end, they kind of, you see who is the core. And typically when it gets here, mom, dad, direct caregiver, whoever it's going to be, is not that said person to really be doing a lot of the coordinating outside of the medical decisions that have to be made, right? Because they have to. Typically, you'll find, especially in our area of the United States, right, you have that tia or, the uncle or something like that, right? So somebody or grandma, who they're rightfully upset, greatly distraught, but they have they're withdrawn from the situation enough to where they're a little bit more clear when it comes to the daily things. And what's important about that, and like I said, and this is why I teach all of my like new residents and stuff too, when we get into that, is there are certain things during other days where it's not actually the day that the kid passes, where you just want them to be able to be a family. And so there's things you have to do from a nursing standpoint, right? That's just, you have to do it. It's involved in the care. But at the same time, like if there's certain other things where it's like, that's not either necessary right now, or it doesn't have to be done now. But it can be seen like, a lot of times we like to provide, ample amount of privacy for the family to just be a family. So if I don't have to be in that room, I'm not. Now that's different because usually we're in there at least every hour, usually more frequently, right? And so finding that family member where it's easy to have that conversation with them, because if you go into, a mom or a dad or whatever of their child that's passing, you're like, hey, I'm not going to be in here unless you absolutely need me. I want to give you privacy and stuff like that. One, they probably didn't receive it and commit it to memory. And then all of a sudden they might actually snap for a little bit and be like, I haven't seen Luke in like 5 hours. He doesn't care. Whereas if you find that other family member that's there involved, you can just like, hey, here's how my day is going to look. There are some things that I have to come in and I have to do that's just part of the process, and this is what it's going to look like. And you should still explain it to the mom and dad, but you need a family that's a little bit more clear-headed. Here's the other reasoning behind why, if I don't have to be in there, I'm going to try not to be, because there's not, a whole lot of time left, and I don't want it to be constantly interrupted with door opening, nurse walking in, here's what I have to do. That's huge, because then they can explain it to that person or the mom, dad, or whoever the more involved family member is. And it'll probably be received a little bit differently because they just will. The other thing is it becomes even more apparent to act on the things that you're seeing, right, with the patient. So one of the biggest things is comfort, right? Because no matter what the underlying thing is, when it gets to that point, there's going to be discomfort. It's not comfortable to pass, but there are ways to make it comfortable. So it's becoming better at understanding what alleviates certain discomforts or what I'm seeing and how to utilize those properly, because now you have shifted into a place where the goal is not necessarily to restore.
Mm-hmm.
So when you're sitting there and you're considering like, man, if I like this one medication might be too much. When you switch into that other thing, and this is I'm not saying this is just for general just know, this is training that you go through and stuff like that, where it's like, no, that is the result that you hope. So you're not assisting anything or like making things worse, but it's like, whereas when you would think, be like, oh, well, I still can't necessarily give this med for another hour. You're using nursing judgment that you've learned and experienced and been trained on to be like, no, that's actually, never mind. This is the instant to do it.
Mm-hmm.
And then I like what you said about yourself about decompressing, because it's important. And in both of our specialties, we do see death more than anybody should. And if you've ever met anybody that's like not affected by it, then it's like they either do a really good job of hiding it and maybe don't cope with it necessarily really well. But taking care of yourself is so important. And whether that's spending a couple extra minutes in your car once you get out of work, or even if you're at work, finding a quiet place to go with a coworker or by yourself or somebody else is affected, to where you can just step away and regather yourself. Because again, the bad expectation is that like we can walk out of a room like that, instantly flip it, going into another room where it's sunshines and rainbows and not be affected or not talk about it. Right. And we talked about that back in like episode 2 and stuff like that,
Mental
because
health.
we started seeing all these memes and stuff come out where you see, call a time of death, and then instantly the video switches and they walk into a room like, oh, your labs look great. And that happens, unfortunately, like that. I mean, because typically, especially in that, like, when you're assigned to that child or something that's in that situation, it's heavy.
Mm-hmm.
So usually your charge nurses or your assignment makers, your other patient, regard, like if it's a 2-to-1 or something like that, a lot of times for you, it's probably more of a 1-to-1. And a lot of times for us, it is too. But if you just happen to be a 2-to-1, your second patient is one where like it's the opposite. You're not in that room really very often at all because they're doing so well. You don't have to be. And in your instance, if that's the case, that's just because there's probably not another bed on another floor, so they get to hang out with y'all for a little bit longer.
Right.
But so you have the two drastic ends of the spectrum there, and you're immediately expected to just constantly flip back and forth, and it takes a toll over 12 to 13 hours over multiple days.
Yeah.
Also, learning your facility's resources when it comes to end of life stuff is my number 2 most important thing, other than, like I said, finding that family member, because the facility is going to have it. To the extent of what they have just depends. But typically, usually what will happen is a lot of times and in this world, this day and age, it's more important, but they'll accommodate more visitors. So visitation policy typically will change because, again, there's going to be people that want to pass through. But again, too, that's where you have to get with that family or whoever that family member that you found is going to be the coordinator, because everybody's going to want to come by. And there might be some people that they don't want to come up or not have the ability to come up or anything of that nature, or don't want to be. So it still needs to be regulated too. Usually your food and nutrition services or whatever will provide, types of food trays or extra beverages, things of that nature, what you would call a bereavement package kind of thing, so that it tries to limit the amount of times the family feels like they have to leave. Because that's the other thing. The families will forget to take care of themselves. They always forget to take care of themselves when they have a child in the ICU or oncology or stuff, just regardless, because they're at the bedside all the time. But they have to take care of themselves even more so during that time, because they're already crumbling. We don't need them to crumble more. So they'll usually, we typically can, provide food, nutrition, beverages, so that if they don't want to leave the bedside, they don't have to, but they have something that they can still nourish themselves with.
And it's just like a tray that FNS will bring up. Essentially, you can just tell like your unit clerk, and they'll bring up like a big tray with like sandwiches, fruit, waters, all that stuff. Just something that way they can all just stay in there and be with their patient as long, be with their child as long as they want to be. But also, like Luke said, sometimes there are family members that just kind of come out of the woodwork, and I think it's important for us to recognize, like, hey, like, use your nursing judgment, like use your social skills. Like, hey, like, I shouldn't be in here probably for this long.
Yeah.
Like, if their child just died, you probably shouldn't be there at the bedside being like, I'm so sorry, giving your condolences a million times.
Yep.
They hurt you the first time.
Yep.
All right. And then they're going through something that's like so extremely traumatic.
Yep.
Like Luke said, yes, make yourself available to them. Be like, hey, I'm a resource. But yeah, also go find that family member that's maybe a little bit more something like I think I found. I always look for like an aunt.
Yeah.
Or something like that that I can talk to and say, hey, like I'm going to be outside doing some paperwork.
Yeah, because you're not far, right? You're usually right outside the room, but you've provided that, ample amount of privacy that you can.
Also, give some privacy. Give some, like, when like mothers are breastfeeding or something like that, we have like those privacy screens. Yeah. Put those screens in front of the doors because all of our doors are glass. So put those screens there. That way they can have a little bit of privacy. Here's the last moments they really can have with their child, And then just take care of yourselves, you guys. I mean, like Luke and I really love fitness. So I always find a release through the stress of work, through fitness alone. But there's times that I'll be at the gym and I start tearing up and I'm like, oh my God. And then I realize I'm just relieving so much stress. And you don't think about it until you start relieving that stress. And then your body is just like, oh my God, what am I going to do with all this? Like you're just realizing what happened last night. So talk about it. Take care of yourself. Some facilities do have hotlines that you can call. So it's important to talk to your charge nurse or talk to your director and say, hey, like I'm going through this, I'm experiencing this. I think it's important that if you need a mental health day to take one.
Yeah.
I think it's very
important. Is. No, and I mean, that's the thing. So it's never easy to do this part of our job ever. And it never will be, right? Because it's just not. But what I will say is, the more that you, because unfortunately it's part of it. And if you're in a certain specialty where it's more so than others, like R2, I mean, it's even more important, but make it a point to seek out those educational opportunities and learn more about the dignity and death process. So LNEC is an organization that is end of life nursing, something care, stuff like that. It's an organization that they're the ones that have kind of set some standards and protocols when it comes to end of life care, how it looks, approaches and stuff of that nature. It's a certification that providers and actually nurses can get. I have it and I still continue to do education and stuff like that because it's not going to change it. Like that's still going to happen. Kids are still going to pass. But the more that you're educated in how to make it a better experience, because the whole point of it, especially in pediatrics, is you can approach it in a certain way that allows the family to start the grieving process. I don't want to say early, but early, that allows them to avoid so many family complications after. Because that's what we don't see when they leave the thing, right? You don't see what happens to this family and the family members and the family interactions after said child has passed. You might hear it through the grapevine, at least for me, because these families are still so involved in everything like that, that it completely destroys families. And a lot of it you can kind of maybe tie back to like, maybe we didn't do as good of a job as we should have with resources or education or starting a certain conversation or things before, or trying to help them get the help that they needed outside of this actual thing here, that it blows up families. Because you might have one parent, if it's both parents or two caregivers that believes one way and the other one that believes the other. And so they're constantly pulling at each other for the decision of what's best for their child until the decision essentially is made for them by God or whatever you believe in, stuff like that. And then as soon as that common bond isn't there anymore, neither is that family. And so then you see, and that's unfortunately part of our world too, is you see these big, huge life changes when it comes to the health of a child completely ruin families and things like that. So it's huge. So seek out and explore those educational opportunities to find how you can be such a better resource when it comes to those times. And it will also help you become better at, I don't want to say deal. I always hate the word dealing with it, because you're not dealing with it. At better being able to cope and take care of yourself, because I promise you, and somebody who's done it a lot more than I ever would have wanted to in 5 years of nursing, it still hits me like a fucking freight train, like crushes me. And there's not a kid that crushes me more than another. They all hit me just as hard. But because I have a better understanding, and if I'm in the situation where I'm providing the care, know that I'm providing the best and exceptional experience that I can for such a shit time, that when it does eventually happen and I'm sitting here and I've allowed myself the proper amount of time to just let it crush me, I can go back and be like, okay, you know what? Like, I remember when they said this because this is something that I did and stuff. And it's like, okay, I did right.
Mm-hmm.
I did right. I'm not, I never sit there and be like, oh, you did good. No, I did right.
Yeah.
This is what the family and that patient deserved. And there is some solace that you can take for being very effective and proper and professional in ushering that child into the next step. There really is.
And I completely agree with you. I mean, like, this is why we all became nurses,
Mm-hmm.
to provide exceptional care to these family members that deserve it. And I think that personally, if you're not planning on doing that when this time comes, because even if you're like, oh, I'm med surge, I want to do tele, I want to do this, accidents happen.
Yep.
Things happen. It's not just because you're in the ICU that you're going to be seeing death, or because that you're, hemonc that you're going to be seeing this more often than not. Like, you need to prepare for it. And if you're not willing to give your all, then you're in the wrong profession.
Yeah, absolutely. But yeah, I mean, so yeah, with that being said, we hope that this, was a little informative.
Mm-hmm.
We also know that, like I said, we
can definitely message y'all.
Yeah, and we liked that we were able to share some stories and spitball and stuff like that. But yeah, absolutely, message us. You can message us individually or hit us up on the A&O Instagram. If you have any, further questions or stuff like that, specifically, especially just, not necessarily just on like I said, the death and dying, but, with just like our specific specialties in itself, or pediatrics in whole, what's worked for us, tips and tricks. Again, like I mentioned, like, finding shadowing or stuff like that. If you happen to know us personally or know somebody that does know us personally and you're in our same area, and you want to try to explore that, I have no problem, still exploring to see if that's an option, or if you're in nursing school, stuff like that. But yeah, man, if you think pediatrics is something that maybe you're interested in, exhaust all resources and avenues that you can to try to get the best experience possible before you have to make that decision. Because the last thing you want to do is make that decision because you think you want to do it, get in there, and then be stuck, and potentially be miserable or not as effective, and like I said, just a snowball effect. So, but Tori, great to be back beside you. It's going to be so much easier editing the video.
We miss you guys
but
a
yeah.
lot, and we're really happy to bring this content to you guys. And I really want to do more educational topics, I think, in the future.
Yeah.
But we just love it. We have so much fun doing this.
Yeah,
we love you guys. And thanks for all the
so
support.
fun. And so I believe, probably our next episode, we'll definitely try to put one out before Christmas again to go in the holiday season. Probably take a little bit of a break over Christmas and New Year's because, again, like I said, it'll be hard for me because I'm gonna take some trips because I gotta celebrate the amazing wife that I have and her sticking with me for 6 years. But I think the next episode we had talked about, we'll have some fun with it. We'll probably send us. Oh, that's the thing. Send us specific episodes of certain medical shows that you either watch or have heard, or clips or something like that. We'll watch them as we're recording, or we'll just flip on an actual full episode of one show and basically just have a daily conversation and have a conversation about what we are witnessing. Yeah, so I know a lot of times they do get a lot of things right in there. They try to, but there are some things where you're like, damn, that's just so wow, find us the most like ridiculous ones. Or if you're getting into the medical profession, nursing or anything like that, and you do watch these shows and you're like, you have questions, be like, hey, watch this scene and tell me how much of it is actually true. Like, that's what we want. Like, we just want to sit down, probably drink a beer or something like that while we're doing it. And I just want to straight up be like, that doesn't go in the nose. Yeah, that's not where that goes. And be like, oh, you're wearing a white coat. What are you doing ambulating a patient? So I kid. Doctors lounge is that way. But anyway, as always, great to record this. Great to have some people that do enjoy what we're doing. Again, I could care less if we ever get 1 million subscribers or anything like that. I just want people to enjoy what we put out and send us stuff to talk about, and just like hearing our opinion or our suggestions and tips and tricks and stuff on things. So thank you guys as always, and we'll see you in a couple weeks. Peace. Follow us on Instagram at alertandorientedrn and email us at alertandorientedrn@gmail.com. That's alert, A-N-D, orientedrn@gmail.com. See you next episode.